Welcome guys. In this video we are going to discuss about autoimmune hemolytic anemia and other anemia related to it. This is the part of the series of hemolytic anemia discussion, third part. In the first part we have discussed about etiopathogenesis, diagnosis and management perspective of the hemolytic anemia in a general. In the second part we have discussed about the causes and in detail about the inherited causes of hemolytic anemia. And this part we are going to look into the acquired causes of hemolytic anemia. Alright. Now, if I say one model disease for hemoglobinopathy, it is nothing but sickle cell anemia. For enzymopathy, it will be G6PD deficiency, and membrane cytoskeletal defect, it is hereditary spherocytosis. Similarly, for acquired causes, extracorpuscular one, the model disease is nothing but the autoimmune hemolytic anemia. Besides this, we also look into the other causes of the acquired or extracorpuscular hemolytic anemia, right? So coming to infection first. So infection, most common one which lead to hemolytic anemia acquired one is malaria, followed by Shiga-like HUS, that is O157 H57 of E. coli, which causes as a bloody diarrhea presentation, and another one is Clostridium perfringens sepsis. Now, this sepsis is life-threatening in nature, mainly due to toxin with lecithinase activity, and this is sepsis is due to the alpha toxin of Clostridium perfringens. Alright. Now remember, this list is not exclusive one. There are other infections also which can present as hemolytic anemia also. Even there are reports of COVID-19 presenting as hemolytic anemia. Now, if you look at this Harrison chart, it mentions about disease and clinical situation in which hemolysis is largely intravascular in nature. Now, remember, a red cell has remarkable property of squeezing through the capillaries narrower than them. Now, but at least there are situations in which when the squeeze through the capillaries narrower than them, there is tear in the RBC membrane resulting into intravascular hemolysis. One is acute and self-inflicted, which is known as March hemoglobinuria. Now, what is March hemoglobinuria, guys? This March hemoglobinuria is an abrupt mechanical destruction of RBC. It was first described in German soldier and seen usually after March 1st or joggers or marathon runners or in barefoot dancer. Okay. Now let's discuss about the case which I have personally experienced. This is about a 52-year-old male, known hyperthyroid, known case of rheumatic heart disease, having mitral valve repair, prosthetic mitral valve repair 4 years back, was doing apparently well, skipped medication few days back, suddenly presented with shortness of breath for a duration of 4 weeks along with palpitation. Okay, so middle age, 52-year-old male, known case of hyperthyroidism on neomarcazole, RHD, mitral valve repair, prosthetic repair was done and was doing well. Now skipped medication for neomarcazole few days. Now presentation is SOB, 4 weeks and palpitation. On examination, heart rate was also irregular. ECG was suggestive of atrial fibrillation, most likely which was explaining the cause of palpitation. And there was bilateral capitation present in chest. There is no pedal edema, no history of chest pain. So initially the differential for this case was kept, like for example, one can be due to heart failure and that can be due to thyrotoxicosis itself. But when blood reports was done, also mitral valve prosthesis is there, mitral valve dysfunction can be there, which can lead to this similar presentation. But when blood reports was done, surprisingly hemoglobin was also 8.2, but pallor was not so much significant with this 8.2 hemoglobin. Alright, and when retic count was done, reticulocyte count was increased, LDH was increased, suggestive of hemolytic anemia. Nevertheless, 2D echo was done obviously to rule out heart failure part and check the mitral valve status. Now let's check the 2D echo. What does it reveal? So as you can see here, so this is a apical 4-chamber view where you can see LA, LV, RA, LV and RA, right? So this is LA, RA, LV and RV. Alright. Now you can check that metallic prosthesis is all seated in this mitral position. How do you know it is metallic prosthesis? Because you can see hyperlucent shadows beneath it. Okay, so this is all seated in its own position, but what other finding that is of our concern? There is paradoxical movement of this septum, left atrium to be dilated, and there is intra-atrial bulging suggestive of atrial fibrillation in the right wall, and this LA dilatation means high left atrial pressure, right? Now if we check in the colored Doppler, there are two sets of rings of color, so obviously in the both systole and diastole suggestive of moderate to severe mitral regurgitation. And if you can check in the colored Doppler, you can see jet along the LF free wall, MR jet is along the free wall and suggestive of significant paravalvular leak. Okay, significant paravalvular leak. Now you can see here and there, both sides of this metallic prosthetic valve, there is a paravalvular leak present. Okay, so idea of discussion of this patient with prosthetic mitral valve is that he presented with SOB and palpitation and anemia, hemolytic anemia. So paraprosthetic regurgitation, if significant present, this patient can come to us with something known as microangiopathic hemolytic anemia, alright, which is acute or chronic in nature and mainly due to the leaky prosthetic heart valve, right? Okay, now from here let's move into the main topic of today's discussion. That is the immune hemolytic anemia. Immunity mediated hemolysis of red blood cell can be of two types. One, that antibody was directed against other molecule in which RBC stands as innocent bystander and gets sliced. It is mainly seen due to when autoimmunity is due to, or not autoimmunity per se, immunity is due to against the toxins or drug, and other antibody directed against RBC. This is what we call to be autoimmune hemolytic anemia, right? Now this autoimmune hemolytic anemia is again further classified as warm autoimmune hemolytic anemia or cold autoimmune hemolytic anemia. This warm and cold is based on the thermal amplitude of the antibodies. Now this classification also holds true and valid for clinical perspective, as symptoms do differ from each other and they have having varied pathophysiology and presentation. Now when do you suspect a patient have autoimmune hemolytic anemia, right? Remember, this is having a abrupt presentation. We are going to discuss about the warm one first, right? Warm autoimmune hemolytic anemia. Remember, this is a abrupt presentation as a triad of presentation mainly you need to suspect. So this is abrupt. Abrupt means they have very sudden onset drop in hemoglobin. For example, hemoglobin dropped from 12 or 13 to 4 within a span of 2 to 3 weeks, and as it is a form of extravascular hemolysis, there will be along with jaundice and splenomegaly. So patient presenting with abrupt onset of hemolysis, jaundice, splenomegaly, very quick progression of disease. In such cases, you need to suspect to be autoimmune hemolytic anemia and go for other specific tests to rule out or rule in the causes. Now, obviously, other investigation for hemolytic anemia will be raised in this case. Markers will be raised. For example, serum LDH is going to be high, no doubt in it. Retic count will be high. Like now, a specific one which you need to go for is direct comp test in such cases. Now remember this autoimmune hemolytic anemia means an autoimmune process is going on in which antibody is directed against the red blood cell. So it's not that antibody is selectively targeting the red blood cell. Some when autoimmune phenomena goes on, it targets almost all of the cells of the body. It also targets the platelets too. So it can be in conjunction with autoimmune thrombocytopenia too. And sometimes autoimmune thrombocytopenia is the earlier presentation than autoimmune hemolytic anemia. And when these two go hand in hand together, we name them as Evans syndrome, which can be manifestation of common variable immunodeficiency or primary immunodeficiency. Okay, so what is the next step when there is a clinical suspicion of autoimmune hemolytic anemia? It is a direct comb test. Now, comb test is of two types: direct and indirect. Direct is for autoimmune, whereas indirect, this indirect is for prenatal testing during pregnancy or before cross-matching during blood transfusion. Now, this direct comb test is diagnostic for both warm as well as cold autoimmune hemolytic anemia. So, what is the step usually incorporated in it is, so it actually detects the red cell antibody, right? So, what is done? It is indirect. So, let's discover the direct comb test first. In which the patient sample is collected. So, patient sample is collected. This is the patient RBC. And if let's say the patient was a case of autoimmune hemolytic anemia, so they will have coated antibody to this red cell surface. Now this blood sample of suspected patient, after collection, antibody against human globulin is added to it. So, from external we add antibody against this human globulin, and this may be mainly IgG, IgM or complement type. Now, if the sample agglutinates, what does it mean? It means that antibody which we added from outside is detecting antibody present in the patient blood. Therefore, patients contain the antibody beforehand. Therefore, this is a case of autoimmune hemolytic anemia. Now remember, this direct comb test can be falsely negative in case of Briggs hemolysis, and 10% of one autoimmune hemolytic anemia is usually comb negative in nature. So, negative test doesn't rule out autoimmune hemolytic anemia. There can be still autoimmune hemolytic anemia going on, and there can be Briggs hemolysis going on, for which this RBC is already fragmented and there is no antibody attached to the fragmented RBC, which can be detected by IgG or IgM complement, which we add from outside. Now, if I speak about the indirect comb test at the same page, what is done here? Here, it is mainly for prenatal testing as well as blood cross-matching in the blood bank. So, patient plasma is collected. So, we collect the patient plasma. And what is the normal place of antibody? Normal place of antibody is obviously the plasma. Let's say this to be patient plasma, and we add the RBC of known antigenicity. That is the RBC which was stored in the red blood cell, which is stored into the transfusion unit. So we add to it. Now after that, we don't know what is present in this patient plasma. Now after that, we add antibody against human globulin, from outside. Now, if after adding all three there is lysis, what does it signify? It signifies that patient plasma contained already the antibody. That's why this antibody against human globulin can identify it. Obviously, right? So, this lysis, red cell agglutination, means cross-matching is negative. Okay. Now, if there is no lysis, cross-matching is positive and blood is accepted for transfusion. Okay. So, this is all about direct comb test and indirect comb test, in which a recipient serum is obtained in indirect one. containing the antibody, and donor's blood sample is added to the tube with the serum. Now, as you can see, recipient's immunoglobulin that target the donor red blood cell forms the antigen antibody complex, and anti-human immunoglobulin is added to it. Now, if there is clumping, means it is positive test result. Alright. Okay. Now, what is done when autoimmune hemolytic anemia is suspected? First step is direct COM test. If it is positive, what is next step? Next step is to check for separate direct agglutinin test for C3 and Ig. Now, as you can see from the chart, if IgG positive, most of the causes for us importance is the one autoimmune hemolytic anemia. And if IgG negative, mainly it can be due to acute or delayed transfusion reaction. Acute or delayed transfusion reaction can be IgG positive as well as IgG negative. Alright, and mainly it can be drug-induced immune hemolytic anemia, paroxysmal cold hemoglobinuria, and cold agglutination test. So from here we can say warm autoimmune hemolytic anemia is mainly due to IgG type, and cold autoimmune hemolytic anemia is mainly due to the IgM types. Obviously, there is an exception to this cold autoimmune hemolytic anemia IgM type. Okay, so as you can check into the table, causes of this autoimmune hemolytic anemia. So it can be divided based on the clinical setting of presentation and based on the type of the antibody, whether cold or warm. Cold is mostly IgM. Obviously, there is exception to this rule, and warm is mostly IgG. Now, primary can be cold agglutinin disease. We will check what it is in detail later on. And one is the primary is idiopathic hemolytic anemia. Now, secondary to viral infection can be there. For cold, it is Epstein-Barr virus, that is infectious mononucleosis, CMV. And for one, it is parvovirus B19, HIV, HCV. Obviously, Epstein-Barr virus can also cause one, but mainly Epstein-Barr virus is for cold variety of autoimmune hemolytic anemia, and viral vaccine. Now, regarding viral vaccine, at the meantime, you can see there are case reports have been reported. It's reported in India itself that autoimmune hemolytic anemia can be secondary to COVID-19 vaccine itself. Okay, so what are the other infection apart from viral which can cause? Mycoplasma infection can precipitate the paroxysmal cold hemoglobinuria, and babesiosis can precipitate one hemolytic anemia. Babesiosis is associated with, guys, it is associated with Maltese cross RBC, right? Now, it can be secondary with other disease. Cold agglutinin disease, CAD here is cold agglutinin disease, is associated with Waldenstrom microglobinemia or lymphoma, or there is malignancy, and autoimmune goes hand in hand with other disease, right? These are friends to other autoimmune conditions like SLE, scleroderma, RA. It can be associated with Hashimoto thyroiditis or post-transplant. Common variable immunodeficiency we have already discussed. It can be eyelash presentation like autoimmune thrombocytopenia and autoimmune hemolytic anemia, which is called to be an Evans syndrome. Okay. Now, this autoimmune hemolytic anemia can be drug-induced. Now, drug-induced part is divided into drug dose dependent and drug dose independent. Drug dose dependent is like penicillin, and drug independent is like methylrobin. Okay, so this is overall classification of acquired hemolytic anemia, autoimmune hemolytic anemia, right? Okay, now what you can see here, this is nothing but the Maltese cross RBC, that is seen in babesiosis. And babesiosis, what does it causes? It causes one autoimmune hemolytic anemia. Okay, so once you suspect this autoimmune hemolytic anemia, when do you suspect? When there is abrupt presentation of extravascular hemolysis and sudden drop in hemoglobin, the other causes has been ruled out, and direct COM test to be positive. Now, how to go and proceed for treatment? Now, how are they coming? This present you. They are coming first of all due to abrupt presentation. At that meantime, what is your clinical decision should be? Your clinical decision should be to check whether it is a life-threatening abrupt presentation or not. So, question that you should ask whether it is a life-threatening or not. If answer is yes, straight away you need to go for blood transfusion first, right? Don't think about the causes, what can be the types. First, save the patient, and we need to go for blood transfusion. And if answer is no, we can avoid blood transfusion and consider steroid or other therapy available to us. Now, what is the issue with blood transfusion in such patient? Now, transfusion is required and mandatory, but however, due to circulating antibody to the red cell itself, cross-matching will always be incompatible with patients of autoimmune hemolytic anemia. Therefore, rationale is to transfuse blood which is ABO compatible, or just to go with O negative blood transfusion. See, whatever blood we are giving to this patient, if autoimmune antibodies are going to target this blood cell, this blood which you are transfusing will also get lynched, right? So cross matching is not required in such cases. Just transfuse ABO blood group or O negative blood group to the patient, and rationale is to save the patient and make a hemoglobin to that target level at least, which will buy us some time for going for main treatment modality. So whether if it is not life threatening condition or we have saved the time by brought some time with blood transfusion, next step is obviously go for specific therapy, which is nothing but steroid. And what is preferred in steroid? Steroid prednisolone is preferred at the dose of 1 milligram per kg. Now, prednisolone 1 milligram per kg results into remission in 50% of cases. Now, another strategy involves combining prednisolone along with rituximab at very low dose. Now, what does rituximab helps? Rituximab helps in prevention of relapse. Now, this low dose is usually 100 milligram per week for a month. Okay, so this is about the treatment part, but sometimes patient cannot respond. Some patient might not respond to this steroid therapy or rituximab, and we label them as refractory cases, refractory autoimmune hemolytic anemia. And in refractory autoimmune hemolytic anemia, immunosuppression with cyclophosphamide is indicated as well as splenectomy is indicated. Now, immunosuppression is done with cyclophosphamide first. Cyclophosphamide also suppresses the bone marrow, thereby followed by immunosuppression. We need to give myelostimulating agent to support the bone marrow, mainly the anti-CD52 myelostimulating agent, anti-CD52, that is LM2-zumab. Okay, and if patient has anemia along with reticulocytopenia, it can be there due to the chronic nature of the disease, reticulocytopenia, or due to the autoimmune effect. We need to supplement the patient with erythropoietin. Okay, now remember, in these refractory cases, besides cyclophosphamide and alemtuzumab, splenectomy is also indicated. Splenectomy doesn't cure the disease per se, but idea is not to control disease but take away the major site of hemolysis. And if major site of hemolysis is taken away, that is splenectomy is done, obviously it also increases risks of infection with capsulated infection organism. So we need to vaccinate the patient. So what are the risks? Risks for pneumococcus as well as meningococcal infection. Meningococcal can be B and A2 types, as well as each influenza infection and seasonal influenza infection increases. So What are the strategies that is used for vaccinating this patient? For pneumococcal, we have two vaccines available, PCB13 and PPSB23. So first dose which is indicated is usually PCB13, and it is given around 2 weeks after the splenectomy. Second dose of pneumococcal vaccine is PPSB23, and this PPSB23 is given usually after 6 to 12 months of duration of gap from the PCB13, following which we need to give the third dose of PPSB23, and gap between two PPSB vaccines should be minimum for 5 years. Booster usually indicated when at the age of 65 years. Okay, so single booster of PPSB 23 is indicated. Now for meningococcal vaccine we have two types, MenV and Men-A. Now Men-A and Men-B is given at 2 weeks. It is usually given first dose at 2 weeks. Men-B is given after 1 month. After 1 month second dose, and Men-A is given after 2 months the second dose. Okay, and when 2 months are completed we give this Men-A vaccine, and the third dose of Men-A is given at 5 years. 5 years third dose of Men-A is given. Now usually no booster is required, but some centers however practice this repeat vaccination of meningococcal vaccine usually after every 5 years. Now each influenza vaccine is given as duration of first of 2 weeks, similar to pneumococcal conjugate vaccine, 2 weeks. It is each influenza B, and followed by 2 months, and thereafter every 10 years each influenza B vaccine is given. Seasonal influenza needs to be taken every yearly during the flu season, mainly due to the October to March around. Okay, so this is about the strategy of vaccinating the patient post-splenectomy in case of this hemolytic anemia. Now let's discuss about the cold type of autoimmune hemolytic anemia. We have discussed in detail about the warm variety of autoimmune hemolytic anemia. So let's discuss about cold autoimmune hemolytic anemia. Cold autoimmune hemolytic anemia, for the sake of discussion, remember it is of two types, CAD or cold agglutinin disease, or can be due to the cold hemolysis. Cold hemolysis is also known as paroxysmal cold hemoglobin. Right, now cold agglutinin disease is mainly IgM mediated, as for most of the cold diseases, whereas PCH, that is paroxysmal cold hemoglobin, is exception to the antibody mediation. It is due to the IgG mediated. Okay, now for discussion of cold agglutinin disease first, this IgM in cold agglutinin disease is directed against the I antigen of red blood cell, right? It is directed against the I antigen of red blood cell. And so what happens in it? First IgM this IgM antibody at 4 degree, that is lower temperature, bind with the I antigen of the red blood cell, this I antigen of red blood cell, and it results into activation of the complement, and when there is activation of complement, C3b moiety comes to it. This is the C3b moiety comes to it. Now when this RBC is warm, usually at room temperature at 37 or body temperature at 37 degrees centigrade, IgM detached from itself. So IgM will detach away. IgM will detach away from this red blood cell, but C3b, which was a complement, remain attached to it, which was activated at cold temperature. What will happen to it? This C3b, remember, is a opsonin. C3b is a opsonin. So when this C3b attached RBC will circulate through liver or spleen, which is the major site of hemolysis, will lead to lysis of this red blood corpuscle. So lysis at liver and spleen, okay, resulting into extravascular hemolysis. All right. Now, if we discuss about what happens in cold hemolysis, remember it is IgG mediated. IgG is one which will act mainly at warm temperature, not at the cold temperature. So what will happen to it? So this IgG is directed against antibody known as the Donat-Landsteiner antibody. Right. Now this Donat-Landsteiner antibody, IgM mediated, is as seen in paroxysmal cold hemoglobinuria against the P antigen of red blood cell. Okay. Now what happens? This IgG binds to it. IgG binds to it at 4 degrees centigrade. But differentiating from cold agglutinin disease is that at low temperature, when IgM was bound to it, it was able to activate the complement. But here it will not, it can't activate the complement as it is IgG bound, so complement will not get activated. What will happen? What will happen at normal temperature at 37 degrees centigrade body temperature? This RBC bound with the IgG, RBC which is bound with IgG, will not detach and resulting into activation of membrane attack complex. Now due to the activation of membrane attack complex, it will lead into severe intravascular hemolysis itself. Okay, so as you can see, cold autoimmune hemolytic anemia mainly of two types: cold agglutinin disease or cold hemolysin disease, which is also known as paroxysmal cold hemoglobinuria. Now cold agglutinin disease was due to the IgM mediated, whereas paroxysmal cold hemoglobinuria is due to IgG mediated. Difference here is that based on the pathogenesis, at which temperature they bind and which temperature they result into lysis. As C3b was bound to it, that is opsonin. So this opsonin mediated lysis occurs in the liver and spleen, resulting into extravascular hemolysis per se in cold agglutinin disease, whereas in cold hemolysin or paroxysmal cold hemoglobinuria, due to activation of membrane attack complex, that is intravascular hemolysis. Right. Now remember, this cold autoimmune hemolytic anemia, which is again two types: cold agglutinin disease and paroxysmal cold hemoglobinuria. Cold agglutinin disease is commonly seen with mycoplasma, then Waldenstrom macroglobinemia, malignancy like lymphoma, and Epstein-Barr virus infection, viral infection Epstein-Barr virus, that is infectious mononucleosis. What is the antibody in it? Antibody in it was IgM. So everything is with M in it. So you can remember mnemonic to be M. Whereas in paroxysmal cold hemoglobinuria, that is IgG mediated, it was earlier said that mainly association was found to along with congenital syphilis, but with almost decreasing incidence of syphilis and decreasing incidence of congenital syphilis. Now the cases which has been reported mostly are idiopathic in nature. So here let's discuss about another case. It is about a 19-year-old male who presented with dry cough, and dry cough was a subtle in nature, not so specific, but his coming in contact with the medical professional was sudden onset jaundice. He was having cough for 7 to 8 days, but sudden onset jaundice along with dark color-colored urine. Okay, so that was the reason for his coming in contact, and when blood sample was taken for analysis, blood sample, that's complete that it was getting clotted easily. So as you can see here, sample was getting clotted easily, and whenever it was, even before in the smear, it is getting clotted. And you can see here, this is the clotted sample, and after gradual warming, it was found to be a normal one. So how do we detect this called autoimmune hemolytic anemia? The steps involved for detection is known as cold slide technique. What is involved here? Here, the blood sample which collected, if in normal temperature will show normal cells, but on freezing will result into clumping. Okay, on freezing will result into clumping. So for this boy, it was suspect to be a cold agglutination disease or paroxysmal cold hemoglobinuria, but it is a more of a reverse of this phenomena because he had a history of dry cough and suggestive of paroxysmal cold hemoglobinuria type presentation, because at normal temperature it was getting clotted, and his respiratory sputum examination was done, it was almost normal. COVID RT-PCR was done, it was negative. Respiratory panel, biofluorescent was suggestive of mycoplasma, and all other pathogenic organism strains were negative. He was started on levofloxacin, and his paroxysmal cold hemoglobinuria responded very well to this treatment. Okay, so after this, let's discuss about the last part of this extravascular defect, that is the toxin or drugs which can cause hemolytic anemia per se without involving the autoimmune system. So what are those? This is a type of immune hemolytic anemia where RBC acts as a bystander, right, innocent bystander, and they are get lysed because antibody are getting activated against the toxin and drug, and whenever RBC surfaces through it, it get lysed. So what are the causes? It can be 100% oxygen, number one. It can be due to methylene blue. It can be due to the oxidative stress and cisplatin anti-cancer drug, and there are some drugs like copper, lead or arsenic which causes lysis by unknown mechanism. Now this leads to basophilic stiffling peripheral smear also. Now in Wilson's disease, which is nothing but the defect in the ceruloplasmin, which is a copper transporter. What happens in Wilson disease is that due to the defect in ceruloplasmin, there is excess of inorganic copper in circulation. Now, exact mechanism how the copper in this Wilson disease causes hemolysis is not known, but proposed mechanism include like damage to the cell membrane, accelerated oxidative damage to the hemoglobin, or inactivation of enzyme in this glycolytic pathway in which RBC membrane is totally dependent, mainly the hexokinase. Okay, so If we check the Wilson's disease classification criteria, Lipsing criteria, we'll look into the detail in the later video once. So you can check that negative hemolytic anemia has also been given a 1 point for the diagnostic criteria uh, for the Wilson's disease, right? Okay. So that's all about autoimmune hemolytic anemia. In the next module, we will be looking forward paroxysmal nocturnal hemoglobin. Okay.